Okay, hello, and welcome to another Rush Generations Health Education Lecture. I'm sorry we are a little bit late, but we are so delighted that you're here. Rush Generations is glad to be your source of information, resources, and health promotion programs that help maximize your well-being and good health as you age. Today is Wednesday, February 14, 2024, otherwise also known as St. Valentine's Day. I am Grisel Rodriguez Morales, Rush Generations Program Director, and I'll be your moderator for today's lecture titled Heart Health in Older Adults. We are delighted to have one of our esteemed Rush colleagues join us today to speak about this important topic. Before I introduce Dr. Okuase, I'd like to first thank our producer, Hannah Weitzman. As she normally does, Hannah will be helping us manage the chat and other aspects during this event, so that we can all have a great discussion. As you know, we are live streaming the lecture via our YouTube channel, where we have dozens of other health education lectures that you can always refer back to. Please feel free to let friends, families, colleagues know about our channel and any of the lectures we've offered, so that they can also benefit from the valuable information that our speakers offer every other week through Rush Generations. We use the video platform Zoom, which allows us to also host a good number of people that join via phone. For those of you in YouTube, please, we ask that you use the chat function to ask questions or to add to the discussion throughout the lecture. We will make sure that your comments and questions make it to today's presenter. And for those of you listening to the discussion via phone, you will also have an opportunity at the end to unmute your audio so that you can ask your questions. We greatly appreciate you joining us today. Please know, as we always remind you, the information offered here is for general informational purposes only, and that for situations very specific to you, we encourage you to always seek additional professional advice so that your specific needs are met. So now up to our presenter, Dr. Tochi Okuwasa. I love that name, Okuwasa. Sorry that I said it incorrectly. Dr. Okuwasa is a professor and director of the cardio-oncology program at Rush University Medical Center here in Chicago. She earned her medical degree from the Philadelphia College of Osteopathic Medicine and completed her internal medicine and cardiology training at the University of Chicago. Her primary research interests lie in the areas of cardio-oncology and cardiovascular disease prevention. Dr. Okuwasa has played a pivotal role in the establishment of various successful local, regional, and national initiatives that aim to enhance cardio-oncology and overall medical education, as well as foster collaborations with the medical community. Widely recognized of her dedication to promoting health equity and actively engaging in community education initiatives. So we are so delighted to have you here, Dr. Okuwasa. The screen is yours.
Wonderful. Thank you so much, Grisel, for organizing this. And thank you, everyone, for having me. I have to apologize. I'm the reason why we're starting late today. I was in clinic, and of course, it's the last patient that I was supposed to see before this ended up taking longer than anticipated. But good thing the patient is doing well. So here we are. So it's really my pleasure to speak to you all today about the topic of heart health in older adults. I'm looking forward to having presenting a great talk and hopefully having great discussions associated with the talk. So I'm going to share my screen, and let me know if there's any problem seeing the screen after I share it. Can you see my screen?
Yes. We're also seeing the notes.
Okay, let me put it in swap. Is this better?
Great.
Okay, perfect. Give me one moment. Sorry, just give me one moment. I think I got it a little bit wrong there. Okay, that's better. All right, so we're going to talk about heart health in older adults. So this is the quick outline we're going to start off with. We're going to talk about why is it that we need to discuss heart disease at all? Why should we have a whole month dedicated to the discussion of heart disease? We'll talk about risk factors.
We can still see the presentation mode.
Oh, okay.
Sorry.
There you go.
Okay, we will do it this way then. Give me one. Okay, so why should we even have a discussion on heart disease? We'll talk about heart disease risk factors, symptoms for testing for heart disease, and what sort of symptoms should we be concerned about, and what kind of tests do we usually order to diagnose heart disease? And then we'll talk about preventive heart disease. And this talk is going to be mostly focused on older adults. And so that's what much of this is going to be focused on. So why discuss heart disease, and why should we have a month dedicated to discussion of heart disease? First of all, what is cardiovascular disease, right? So we talk about heart disease, and then you hear about cardiovascular disease, and I've had patients ask me, what's the difference between the two? Overall, when we talk about heart disease, we're focusing on just the heart itself. But then there are a whole bunch of things that affect the heart, or that the heart affects, right? So like the arteries that come off of the heart, and the heart that supplies blood to the kidneys and to the brain, and so on and so forth. So when we talk about cardiovascular disease, it is a group of blood and heart disorders. So we're talking about not just the heart, we're talking about the heart, but also all the other systems that feed off of the heart when we're talking about cardiovascular diseases. So cardiovascular disease will include both heart disease and stroke when we're talking about cardiovascular disease. And also, of course, also poor circulation in, say, the legs or things like that. Those are all under the auspices of cardiovascular diseases. So cardiovascular disease is the number 1 cause of death in the US and worldwide as well. And 1 out of 3 deaths worldwide are due to cardiovascular diseases. I want you to stop and just think about it for a little bit. 1 out of 3 deaths is due to cardiovascular disease. So it is the number 1 cause of death overall. And the reason why we need to talk about it, the reason why we need to dedicate time to discussing it. So, in 2020, we all know about COVID-19 and how COVID-19 affected many people, caused a lot of deaths. COVID-19 was the reason why a lot of people ended up not going to the emergency room, even if they were having chest pains or they were having shortness of breath, typical symptoms for concern. A lot of people ended up not going to the emergency room because they felt, oh, I don't want to go and get COVID. But honestly, even that 2020, when there were a lot of deaths from COVID, heart disease was still a number 1 cause of death in the US, and cancer was still the number 2 cause of death in the US. So I want us all to think about heart disease, and it's one of those issues that needs to be discussed again and again and again until we can slow down death from heart disease and slow it down to the point where it's no longer the number 1 cause of death. And so 1 in every 3 deaths is from heart disease and stroke. We talked about that. So 1/3 of people die from heart disease or stroke. 2,200, these are the numbers, the raw numbers. According to the Center for Disease Control and Prevention, the CDC, 2,200 deaths per month, 2,200 deaths per day, 66,000 deaths per month, and almost 1 million deaths per year. So that tells you a lot. Who can die from heart disease? I think a lot of people, because a lot of the research from the early 2000s were focused on studying men and heart disease, a lot of people don't think about women and heart disease, but who can die from heart disease? Men can die from heart disease, 1 in 4 men, and overall 1 in 5 women. But I tell you that women typically catch up pretty fast to men, right? Once they hit menopause. So once a woman hits menopause, that risk of dying from heart disease actually starts to approximate, so it becomes very close to that of men. And in fact, people, the data has shown that more women that are postmenopausal die from heart disease more so than men. So heart disease is a problem with both women and men. And I want us to start thinking about it that way when we're talking about heart disease or cardiovascular diseases. So what are the risk factors for heart disease? Age, and that is what much of what this talk is all about. Age greater than 45 years in men, so pretty young. Age greater than 55 years in women. Usually those women that are 55 and above would have hit menopause by then. Family history of premature heart attack. I think most people know this already, especially in first-degree relatives. So if you have a first-degree relative, parents, siblings, children, men above the age of 55, for women relatives above the age of 65, then that constitutes a risk factor for heart disease. Other risk factors that we know and think about, usually high blood pressure, hypertension, that's a major one. Diabetes, another major one, abnormal cholesterol levels, smoking history, weight, when people are obese, poor diet or a non-cardiac diet, physical inactivity, so people that are not moving much, and then increased stress. So these are all the things that lead to higher risk of people having heart disease and dying from heart disease. And of course, for the purposes of this talk, we're going to focus on those people that are older, and which by itself constitutes a risk factor for heart disease. The risk factor, age, is the strongest risk factor for heart disease. And the thing about age is that it is compounded by other factors, right? Frailty, as people get older, they don't move as much, they're weaker, their muscles are weaker overall, they're more frail, they're more liable to fall, and a whole bunch of other things. And this compounds the risk factor of the age as a risk factor for heart disease to begin with. Obesity is another thing that compounds age. People don't think about this, but as people age, because their metabolism tends to slow down, obesity becomes a major issue as people get older. And then also diabetes, because of obesity, diabetes also becomes a major problem as people get older as well. I think I mentioned this earlier, older women. So again, younger women are less at risk for dying from heart disease than younger men, but older women are at higher risk for heart disease than men of the same age. And they're at higher risk for dying from heart disease than men of the same age. Both at higher risk due to age. And the general idea why older people are at higher risk for heart disease compared to younger is the decline in sex hormones, right? So for the women, estrogen basically goes to nothing as they get into menopause. And for men, as they get older, their testosterone levels start to fall. So when you think about cardiovascular disease in the women, in the United States, men and women, this is what we see. So men are represented in the blue bars, while women are represented in the red bars, right? You can see that men are at higher risk as they're in the younger ages, but by the time they get to their 60s, they start to be about equal in men and women, and then they flip once we get above 70s and 80s. But the most important thing I wanted to show with this slide is that you can see how there is an increase in risk as people age, whether you're a man or a woman. It's very, very obvious, right? You can see it's like a stepwise increase in significant increase in risk as people age. In terms of percent of the population, less than 20% age 20 to 39, about 40% age 40 to 59, about 70% age 60 to 79, and greater than 80% risk of cardiovascular disease in the US in men and women with age 80 plus. So it's a major problem. And this is the reason why it is a major cause of morbidity in the US. According to the American Heart Association, the new cases of cardiovascular disease in US men and women are, this is just what I talked about, the numbers already. So types of heart problems that people can have, high blood pressure, high cholesterol, we talked about a little bit. The other problem is arrhythmias, right? I think most people have heard of AFib or atrial fibrillation as a major arrhythmia that people can have, especially as they get older. This is a major problem for heart disease because it increases two major problems, the risk of two major problems that we think about. Number one is the risk of stroke that comes with atrial fibrillation. And number two is the risk of heart failure that comes with atrial fibrillation. So this is particularly very, very relevant, especially as people get older. Risk of heart valve problems. So as people get older, they're at risk for having aortic stenosis or tight heart valves or leaky valves as they get older. And this is really a function of age because people tend to build up a lot of calcium on their heart valves as they get older. And so they're at risk for these. And people that have valve problems may end up requiring a percutaneous procedure or minimally invasive procedure called TAVR for the aortic valve or MitraClip for the mitral valve, or they may end up requiring open heart surgery. We tend to do more of the percutaneous procedures as people get older rather than doing the open heart surgery, which we tend to reserve more for the younger population where the risk of surgery is on the lower side. They could develop other heart problems that can develop pericarditis, which is inflammation of the sac that the heart sits in, that can cause fluid to build up around the heart and so on. The risk of stroke, which we talked about with atrial fibrillation, but even by itself, without atrial fibrillation, stroke risk is also increased as people get older because those blood vessels that supply blood to the brain tend to build up atherosclerosis in those blood vessels, which can then go on and cause a stroke. Heart attack, of course, if you could talk about stroke, you have to talk about heart attack. The same way people can build up atherosclerosis in the the blood vessels that supply blood to the brain to increase the risk of stroke. They can also build up atherosclerosis in the blood vessels that supply the heart arteries, in the heart arteries specifically, to increase the risk of a heart attack, which basically means that there is a rupture of that atherosclerosis that leads to people forming a clot in there, reduces blood flow to the organ, whether it's the brain or the heart, that then leads to a stroke or a heart attack. And then, of course, diabetes. Those are all the types of heart issues that people can have. High blood pressure is the most common heart condition in people older than 75 years. And that's really a major cause of morbidity and mortality in this population. And then coronary heart disease and heart failure are the next most common. What are the major factors that promote cardiovascular disease, especially in older adults? And this is an image or a schematic that shows this very nicely. As people age, they become more frail. We kind of talked about that. It leads to what we call oxidative stress or mitochondrial stress, which basically just means processes, hormonal processes that end up increasing stress and cell death of some cells within the heart, either the heart muscle or the heart arteries itself. And overall in the body, these predispose people to atherosclerosis, like we talked about, obesity and diabetes, like we talked about, and then hypertension, heart attack, poor circulation in the arteries, in the legs and other parts of the body, like we discussed. This then leads to cardiovascular diseases in the elderly, because all of these processes are more common as people get older. So that's why we have all of these. As you talk about cardiovascular disease in the elderly, all of these processes also can lead to electrical system abnormalities, which increases the risk of AFib or atrial fibrillation, like we talked about, and other sorts of heart problems that have to do with the electrical system, like heart block, which could lead to people requiring a pacemaker also. Those are all part of the heart electrical system issues that people can also have. And heart block basically means that the electrical rhythm that's supposed to make the heart pump is not quite going through as well as it should. And when that happens, you need a pacemaker to help pace the heart and get that going. And all the also environmental and genetic and epigenetic alterations can lead to all of these issues in the elderly. And all of these milieu eventually creates that picture of elevated cardiovascular risk as people will age or get older. Normal aging causes the heart and blood vessels to stiffen, which increases cardiovascular disease. And this is very, very interesting. Over a lifetime, 9 out of 10 individuals will have high blood pressure, which is, and as people get older, systolic blood pressure, which is the top number, blood pressure increases as people get older. And the heart rate also declines as people get older. When the heart rate declines, people are going to need a pacemaker eventually if it makes them symptomatic or if it makes them develop symptoms. And as blood pressures increase, you have all of these cardiovascular disease risks increase as people get older. So what are the typical symptoms that we think about, right? There are typically a bunch of symptoms that we tend to think about. Chest pain or chest tightness, I think most people know this. Upper body pain, so you can have pain in the upper body that radiates to the jaw, to the neck, to the back or arms. That's really concerning. Difficulty breathing, especially if it's sudden. Or even if it's subtle, you should still talk to your doctor about it. Sweating, especially if it's sweating. It's not a hot day, just you're sitting down, you just start sweating. Now, of course, women sweat because of menopause, but this is sweating out of the ordinary. Vomiting or nausea. You know, I've once been in the emergency room and I had this patient that just came into the hospital and all she had was just nausea and vomiting. And they did an EKG because the emergency room does EKGs on practically everybody, especially if they have concerns. And this lady had whopping, what we call SC elevation. So they were having a heart attack and her main presenting symptom was vomiting and nausea. And she thought she just had food poisoning. So that's really very relevant. Dizziness or lightheadedness, especially if it's out of the ordinary, and impaired vision. So usually, like if somebody has problem with their carotid arteries, visual problems may be part of how they present with problems, okay? Symptoms of heart attack can be a little bit subtly different in men versus women. So it's important to remember that. The typical chest pain that we think about, or shortness of breath, or discomfort radiating to the back or neck or jaw or shoulder, those are typical in men. In women, those are the atypical, what we call atypical symptoms: sudden dizziness, heartburn, colds, breaking out in a cold sweat, unusual fatigue, nausea, vomiting. Those atypical symptoms that I talked about later, those tend to be more common in women. And so, you know, those are usually acute symptoms that is kind of like, I need to get to the emergency room, I need to be concerned right now. But other symptoms that we can think about, just scheduling an appointment with the doctor and just kind of asking the doctor, should I be concerned about this? This one, you don't necessarily have to go to the emergency room, but you should be concerned enough to go schedule an appointment. if there's fluttering in the chest, because that could mean an arrhythmia or AFib or something like that. Fast or slow irregular heartbeat, like a lot of people have Apple Watches now, they can sense that there. High blood pressure, a lot of people tend to focus on high blood pressure. We talked about that being a major problem as people get older, but low blood pressure is also a concern, because if people have low blood pressure, it could mean that they're having a heart attack. It could mean that they're having heart failure. It could mean that they're having an arrhythmia. So I also want people to think about the fact that low blood pressure could be an issue as well. Lightheadedness, right? Because that could come from people having a low blood pressure, and lower body swelling. So like swelling in the legs or the thighs or that sort of thing, that usually, not all the time, but can signify heart disease, and people should get checked out, make an appointment to get checked out if they have any of these. Common medical tests that we use in diagnosing heart conditions: blood tests. So you could check overall your cholesterol, whether you have diabetes or not. And if people are having chest pains or shortness of breath, you could check your heart enzymes like the BNP or the troponins to try to see if there's any acute process going on. And EKG, which I think a lot of you know, is that graph paper that we do in the office that you just lie down on the table, and we just kind of attach these leads to your chest and take picture. The echocardiogram, which is an ultrasound of the heart, we use ultrasound gel, put that on the chest, and then we take pictures of the heart. It usually takes about 45 minutes to an hour. A stress test, which could be exercise stress test for those that can exercise or walk on the treadmill, or chemical stress test for those that cannot walk on the treadmill. So I know whenever I tell patients stress tests, a lot of them, a good number of patients say, well, I can't exercise. I'm like, no, don't worry about that. We can do a chemical stress test. So that just basically means giving you a medication to make it seem like you're exercising, or to give the physiology of exercise that then makes it easier for us to detect a blockage of your heart arteries. Coronary angiogram, that's the one I was talking about, where we go through your groin or your arm to take a look at your heart arteries, see if you have any major blockages. If there are major blockages, we could end up putting in a stent, or if there are no major blockages, then nothing gets done. If there are major blockages, sometimes, depending on how bad it is, the patient may end up needing to go for a bypass surgery of the heart, or what we call CABG. Magnetic resonance imaging, which is an MRI, so cardiac MRI, which detects conditions. People have heart failure. We're not sure of the reason they have heart failure. That's usually our go-to test, right? We talked about, people that had COVID and they were having all these myocarditis or inflammation of the heart muscle because of COVID. The cardiac MRI was the test to do in that sort of situation. And then heart CT scans, which can be used for a bunch of things, like detecting calcium in the heart arteries or calcium in the aortic valve if the aortic valve is tight. We can also use it to take a look at the heart arteries as well, rather than doing an angiogram. The only disadvantage using it to look at the heart arteries, we can't put in a stent right away. So if we look at the heart arteries with the CT scan and there is a blockage, then we have to end the CT scan and then send you to the cardiac cath lab to undergo another angiogram and then get a stent put in. So usually we do the CT scan in people that are not high risk. We don't think that they're probably going to have any major blockage. Then that would be the time to look at the heart arteries using a CT scan. And then we also use the CT scan to detect other things like a hole in the heart or sometimes clot in the heart, that sort of thing. So this is the last set of slides. How do we prevent heart disease? How do we think about it? And what are the sort of things that we do to prevent heart disease? Well, the American Heart Association has these life essential 8s, directing us on the sort of things to think about, 8 major items to think about as we're thinking about preventing heart disease. Eating better. So a heart healthy diet that's heavy in fruits, vegetables, lean proteins, nuts, seeds, oils, and non-tropical oils like olive oil or canola oil. This is typically the Mediterranean diet. I usually just tell my older patients, focus on a Mediterranean diet, fish rather than meat, and so on and so forth. Manage the weight. Again, we talked about older people having more problems with weight gain and obesity. So that needs to be managed, because even though you can say, oh, I'm older, it doesn't really matter. That's not true. That can actually shorten an older person's life. So it's really important that the weight is managed. Be more active. So physical activity is very important. I usually just tell my patients, just walking. You don't have to go run a marathon or do Zumba or anything like that. Plain walking is a great form of exercise. The beauty of walking is, for those that have knee arthritis, which people tend to develop as they get older, walking is great, because walking helps strengthen the knees also. In addition to helping the heart, of course, will help strengthen the knees also and make arthritis less of an issue. Plus, it's less pressure on the knees overall. Also, water exercises are great for arthritis as well. Control cholesterol, again, with diet. And sometimes your doctor may put you on a medication like a statin to help better control cholesterol. Quit tobacco smoking, that goes without saying. Everybody has heard a lot about tobacco smoking. Manage blood sugar for those that have diabetes, that should be managed and managed aggressively. Healthy sleep habits are great. Basically, stress reduction is particularly important, and then managing blood pressure, which we've talked about a few times. And we're going to talk about some of the goals. I always tell my patients, know your numbers and alphabets of prevention. That's important. So in terms of alphabets, being aware of heart disease risks is particularly important. Making sure that you're taking aspirin if that's needed. Making sure that your blood pressure is controlled, making sure that your cholesterol is controlled, that if you're smoking cigarettes, that you quit, that you're eating a healthy diet and managing obesity and your weight, that you're managing your diabetes, and that you're engaging in exercise and stress reduction. So here are the numbers. For hypertension, goal blood pressure, according to the American Heart Association, is less than 120/80. In older adults, as people get older, we become a little bit lax with that. But I still would say, and I don't think we know the exact goal blood pressure as people get older, especially in elderly patients. But we usually, I usually would say even in older patients, less than 140/90 is still a reasonable goal. So, and when I say that, I mean people that are in their 80s and 90s and above. Those are the people that I would usually use a lower cutoff. But for the most part, for most of the population, about 120/80 is definitely reasonable. Pre-diabetes, hemoglobin A1C, which is a measure of the average blood sugar for the last 3 months, of 5.7 is considered pre-diabetes. Diabetes is considered 6.5 and above, A1C of 6.5 and above. In older adults, people older than 70 to 80 years old, we say A1C of about 7 to 8 and is reasonable for that population. So that's the way we think about it. Abnormal cholesterol, we use your cholesterol to calculate your 10-year risk of having a heart attack and stroke, and that 10-year risk should be under 7.5 in order for us not to put you on a cholesterol medicine. But usually if it's above 7.5, then usually we need to do something like put you on a cholesterol medicine and discuss diet with you to help control your cholesterol. Quit smoking, and when's the time to quit smoking? The number is now, basically. BMI, we usually would say a BMI under 25 kilograms per meter squared. So your BMI is your weight that takes your height into account. Under 25 is good. Greater than 30 is considered obesity. In older adults, about 30, right? So 27 to 28, getting up to 31 to 32 as people get older is reasonable. But again, anything more than that is concerning for increased risk of heart disease and decreased longevity. Diet, we already talked about low in saturated fat, sodium, sugar, calories. Mediterranean diet in older adults is actually a very good one. Exercise, American Heart Association recommends 150 minutes of moderate intensity exercise like walking per week, 75 minutes of high intensity exercise like jogging or playing tennis or that sort of thing, or swimming, about 75 minutes per week. So for those that are walking, which many of the population can engage in, then 150 minutes per week is very, very reasonable. And that's 30 minutes 5 days a week, 50 minutes 3 days a week, not a whole lot. It's definitely very doable. And for when patients complain, oh, it's cold outside, I can't walk outside, I usually say, get a treadmill, get a stationary bike that you can use at home, or go join a gym. Or if you're worried about getting to a gym because of germs, the other thing that you can also do is get a peddler. These days, is that peddler that you can sit in a chair and you can just use it to exercise. That's also very useful. And then, of course, stress reduction, which we've talked about. Yoga. There was just this recent study that just came out that I was listening to NPR today, and we're talking about people in China studying Tai Chi and finding out that Tai Chi, which involves certain movements along with meditation, actually reduces and controls blood pressure pretty well, more than jogging, more than walking. So that's actually a very good way to reduce stress and work on controlling your blood pressure and exercising at the same time. Influence of physical activity on cardiovascular risk and quality of life, especially in the elderly. Physical activity in the elderly influences cardiovascular risk because it does a lot of things. Overall in life, it improves your mental function, improves the quality of sleep, decreases pain, improves function of osteoarthritis, like I talked about, especially water exercises or walking. Those are so good for arthritis. Physical activity also improves blood pressure from a heart standpoint, improves your blood pressure, decreases coronary artery disease and peripheral arterial disease. So increases circulation in the legs and other parts of the body, improves your cardiac output, which is how much blood your heart pumps per minute. That it does a very good job of helping that. When people have symptoms of angina or shortness of breath or palpitations, physical activity and exercise also helps those. improves your walking distance, basically conditions you, and reduces the risk of obesity. And also you control your blood sugars better, because physical activity and exercise sensitizes your cells to the effects of insulin that your body releases. So that's really good for diabetes. And we know that as people age, function and mobility decreases. And so being active is the best way to slow the loss of muscle and maintain aerobic activity and conditioning. We know that many older adults want to remain independent. They do their best to remain independent, but all that independence is going to decline as the older people age, unless action is taken to prevent it, to preserve it. So walking or physical activity, whatever form you can do, is very, very important in this sense. And how about caregivers? What can caregivers do to help seniors protect their hearts? They can reduce stress, whatever sources of stress that particular person may have, provide a heart-healthy diet, encourage rest and encourage physical activity like we talked about, create low-level exercise regimens that whatever, if it's a senior that's much older that is not very active, low-level exercise that he can engage in, or physical therapy. I send my patients to physical therapy too. Offer medication reminders however they come, and then watch for signs and symptoms of heart disease or change in heart health, which they can report to the doctor. And it's really important that people that are caregivers for older adults that it's a shared decision-making process, basically, in terms of discussing their cardiovascular risk. So we have to think about frailty or whatever comorbid conditions that the older adult has and what their mental capacity is, and get a general sense of their life expectancy from their doctor as well. How many medications are they taking? So all of these we have to take into account when we're making decisions about whether they should really get that cardiac testing done. You know, I've had patients that are so frail that even though I know that they weren't going for cardiac catheterization to possibly put in a stent, I say, you know what, this is not the right thing to do for this patient. I'm only going to harm them more. You know, like in medical school, we were told, first do no harm. I have to say to myself, am I going to cause more harm if I send this older patient who's very frail and who's debilitated to the angiogram, or am I going to do good, right? I have to ask myself that question before I send them for testing. So that's really very important. And again, shared decision-making, discussing goals of care. Some older people don't want too much done. So those are all things that we have to do as we're managing older people and their cardiovascular risks. And then using technology to manage cardiovascular risk. A lot of older people, we call it gerotechnology. A lot of older people don't, I can tell you, my mom, don't even bring a smart anything near her. She doesn't want to hear, she doesn't want to learn. She's like, oh, that's for you and your generation. But it's really, really important that for those that are willing to learn, that we teach them. I have older people in my clinic that are very, very good with computers and using their smartphone to exchange my chat messages and so on. If they're not able to, this is where their family members come in. Their family members can help them navigate all of that to make sure that there's constant communication with the physician as necessary, and to help manage their health. And that's also great because you don't have to keep coming in for clinic appointments if things can be managed with technology remotely. And then this is the last slide talking about health tips for older adults. Stay healthy, know your blood pressure, be active, connect with others, bring your list of medications whenever you're coming to a doctor visit so that they can review it. And if you're writing the list is a big chore, just bring in the bag. In fact, I tell my patients to just bring in their bag because the lists are not always updated for a lot of patients. After any setback, like getting admitted to the hospital, physical therapy and rehab is particularly important to get you moving again. So that's important. And then ask for help if there's any distress or loneliness or problems. We have social workers that can help get things set up for our older adults to help maintain a healthy lifestyle as much as possible as they age. And then there's always discussions about goals of care and sharing information with loved ones. So that's particularly important. And then planning for the future is particularly important, whether we're talking about cardiovascular health or other health conditions as well. And I will stop there. Thank you so much. It's been a pleasure speaking to everyone today.
Thank you. Thank you so much. So much great information in there. So one of the beauties of us recording these lectures is that people can always go back and review and think a little bit more about everything that you just said now. So thank you for all of that. For the callers, this is your time to dial *6 if you will have any questions. Otherwise, we'll go through other questions. Go ahead.
My name is Laura. I have two very quick questions. Why is it that doctors do not, when they take the blood pressure in both arms? And why is it that doctors do not test the liver before putting patients on statins? And I will just listen.
Yes. So for the first question about blood pressures, technically speaking, when we check blood pressures in a patient for the first time, we're supposed to check it in both arms the first time. The general idea being that if they have some sort of dissection or anything with the aorta or some curviness of the aorta that can cause differences in blood pressure, we can monitor or we can assess it with that. And then the other thing that's good about checking blood pressures in both arms is you may be checking blood pressures in one arm and thinking the blood pressure is controlled, while if you do it in both arms, you find out that the other one may be higher. And it's actually the higher one that gets blood flow to the brain. So checking it in both arms is important. Why don't we doctors do it? It's because of time. So technically speaking, it really is just time in clinic. It is the right thing to do, I will tell you that. And I do it in some of my patients when I have concerns, but I don't do it in everyone. And also because finding those discrepancies in blood pressure measurements is not very common. So what I tell my patients is many patients measure their blood pressures at home these days. And so what I tell patients to combat that is when you're measuring your blood pressures at home, at least for the first few times, measure it in both arms and write it down both arms so that we can see if they're about the same. And that usually helps. That usually helps quell that. So thank you. That's a very great question. The other question that you had was about
testing liver before putting on statins.
liver testing. Yes, that's true. Thank you. About testing the liver, it used to be that we know that statins can affect liver function. And it used to be that in the past that we were very, very anal about making sure we check the liver test before starting a patient on statins. And actually now we still should do that because statins can cause abnormal liver function tests. And but one thing that we're finding is that statins, the risk of abnormal liver function tests with statins is lower than what we thought initially. So we used to think it was much higher than what it is, but the studies have shown that that risk is so low, it's less than 1%, a very low risk. So we're no longer as anal about checking the liver function as we used to be. And in fact, our guidelines recommend that when we put a patient on a statin, it used to be that in the past, we would bring them back 3 months later and then 6 months later to check their liver function, make sure it's doing okay. Now we don't do any of that. So we put you on a statin and we just kind of let you be. I will tell you that for me in my clinic, I still check the liver function before I put a patient on a statin because I want to make sure that I know exactly what their baseline liver function is before I put them on a statin.
Thank you.
And related to that, if you don't mind, I know that another caller on mute, but a question about the statin drugs to lower the cholesterol. It's effective. So you see that it's effective because when you go back 3 months, it goes down. But how is it that it's determined that it's no longer needed? Because people are told that diet contributes and people start being more active, eating healthier, but continue to take statins. How is that determined?
So that's a very good question. The question about taking, and I've had patients ask me this question, oh, do I get off the statin or am I on it forever? Yes. It's really hard to say to a patient, it's time for you to come off of your statin. So what happens is It's a two-pronged approach. You put somebody on their cholesterol is elevated. If it's mildly elevated, I usually would, and if it's mildly elevated, and there are not many other risks, like they don't have heart artery blockage or they've had a heart attack or all of that, or they don't have diabetes. If it's just mildly elevated cholesterol and no other risk factors, I would say work on your diet, work on exercise. Let's bring you back in 3 months and let's check it again. That's what I do. But if it is more moderately or severely elevated and or they have other cardiovascular risk factors that are major or cardiovascular disease, I would say we would need to put you on a statin anyway. So if a patient already has a problem, let's say they have diabetes, the guidelines are that we put you on a statin regardless because of the risk of coronary disease. So remember, it's not just that the statin lowers the cholesterol, it's also that it has what we call pleiotropic effects. So it reduces your risk of heart attack and strokes independent of the level of cholesterol. So it's those other benefits that we're getting when we say that somebody has heart disease of major sorts, or they have major heart disease risk factors, that it benefits them to go on a statin therapy. So again, if they don't have any major risks, then you can work with diet, but otherwise, and that's the reason why it's hard for us to take a patient off of it, right? If somebody has coronary artery disease, I can't say, okay, your cholesterol is controlled now, I need to take you off of you, because again, I'm getting the other benefits of preventing future heart attacks with the statin therapy.
Mm.
Hi, my name is Constance Hackett, and I'm calling because I take anti-inflammatory for arthritis. And is there a factor out in insulin for diabetes? So when you use the statins according to the inflammatories, they have a reaction, and also with the blood pressure. When you wear one of those devices, should you not put it on the left side because that's where the blood pressure is being taken, or just leave it on the left side?
Okay, so in terms of inflammation, statins can be anti-inflammatory to a certain extent, but the kind of inflammation that the statins control will be inflammation that has to do with the heart arteries building up plaque or building up atherosclerosis on the arteries. That's this type of inflammation that they control, but they will not control the kind of inflammation, at least not to a huge extent, control the inflammation that has to do with things like arthritis, right? So that's a totally different issue. In terms of arthritis, we say, one great way to control inflammation are NSAIDs, right? So Motrin, Advil, ibuprofen, naproxen, those are the non-steroidals. But those are medications that we get concerned about in people with heart disease, because those medications would increase the risk of heart attack and stroke, and will also increase the risk of kidney problems. And will increase the risk of stomach issues and reflux and so on and so forth. And so we tend to be careful with these medicines. We tell patients, if you have to take it sparingly. Tylenol is probably a better option for controlling blood pressure, but unfortunately, Tylenol is not an anti-inflammatory. So that's inflammation. Hopefully that answers your questions in terms of inflammation. In terms of the blood pressure monitoring, it doesn't have to always be on the left side or on the right side. It doesn't have to be one side or the other. The only situation where I tell a patient to put it on just one side is, for people that have had breast surgery, where the lymph nodes have been removed on one side, we usually prefer to do it on the other arm, because there's a concern that blowing out the blood pressure machine on that arm could actually make the drainage of the lymphatics lessen, which can cause more swelling in that arm. The other situation is, like I was saying earlier, if they have different blood pressures in both arms, the one that's higher should be where we're getting the blood pressures, because that's what supplies blood to the brain. But for everybody else, it really doesn't matter what side of the arm you get your blood pressure. As long as your blood pressure is about the same on both arms, you can get it any arm.
Okay, because I know when you wear those devices to check your numbers on your diabetes daily, they tend to sometimes don't put it on there because it could affect the monitor, the device that you wear.
For diabetes?
Yes, ma'am.
Okay. It would affect what monitor? The blood pressure monitor?
The monitor, we have to test our sugar daily, those devices.
Yeah, I maybe this is a company specific thing. I don't know anything about this particular company or the device.
Okay.
Thank you so much.
Those are the monitors that we put a machine up to, and they give us our count of our daily number.
Yes, ma'am. I honestly don't know anything about it. Again, some companies are pretty specific about certain things, but that does not generally count for general health. So it's hard for me to comment on that.
Okay.
Well, thank you so much. I'm going to make a comment before I ask 2 questions that we got, and I'm trying to get you out of here very soon so that you can go back to your patients. I know they're waiting. The family caregivers. I love that you mentioned how the family caregivers can also contribute to this. Many times it's not only about the house cleaning or the medication management. I mean, encouraging physical activity. It helps not only the person, but also you as a family caregiver can also get away from
That's true.
the confound of the home, which is healthy for both people.
That's true.
The questions that came up in the YouTube channel, the person says that they like nuts and eat them all kinds frequently, but if there are any certain nuts to avoid or that contributes to heart disease.
Yeah, that's a very good question. The nuts that you say a no from a cardiovascular standpoint is macadamia nuts, right? So if you like macadamia, I know a lot of people like macadamia nuts, but they're very high in saturated fat. And so we usually don't like people eating, I mean, once in a while, I guess is okay if you really like them, but those are not the healthy nuts that we talk about. Peanuts and cashews are okay. They're not as bad as macadamia, but they're okay. But when we talk about healthy nuts, the ones we think about are walnuts, are pecans, and then of course seeds like sunflower seeds, safflower seeds. There are a couple of other nuts that I'm kind of not thinking about right now. That are almonds. Almonds are great too. So there are a bunch of other nuts. Those are the healthier sort of nuts that we usually think about. Just make sure that they're not heavily salted, because the salted nuts, salt, of course, increases the risk of blood pressure. So that's something that people need to watch out for.
Good point. Good point. All right. Then the importance of dental health in heart disease or heart health.
Yeah, so there've been some studies out there that have linked having poor dentition with inflammation, which increases the risk of atherosclerosis and heart artery blockage. Also can increase the risk of people developing endocarditis, which is infection of the heart valve, which can end up people having surgery because of that. So good dental health and good dentition is particularly important to help protect heart health overall, because for these reasons.
All right. Well, the last one, and I think that you covered this, but just so that a person doesn't feel that we didn't ask, but then when checking for heart disease, what should we be checked during a physical exam along with the blood pressure, or what tests should be scheduled on a regular basis?
Yeah, so along with blood pressure, they're going to measure your pulse or your heart rate. If it is high, that's a concern. If it is too low, that's a concern. Normal pulse or normal heart rate is about 60 to 100. Okay, so higher than this, the doctor should definitely get an EKG. Lower than that, they should definitely get an EKG, because they want to know what kind of rhythm they're dealing with. And it doesn't necessarily mean there's anything bad happening. It may just be that particular patient's heart rhythm, but we need to know exactly what we're dealing with. So getting that EKG would be particularly important. They may even have you wear a heart monitor. So blood pressure, your pulse, your respiratory rate, so how fast you're breathing per minute is part of the vital signs that they get in the hospital. Doesn't necessarily link to heart. That's more of a lung issue, but still that's important. Getting your oxygen saturation, of course, is important. I think most people knew about oxygen saturation during the time of COVID, particularly. So that's particularly important. And then your weight, from a heart standpoint, the weight is important as well, because that's how we determine obesity. So those are what we call the 5 major vital signs that a doctor any basic physician should get in clinic. So that's one. Then in terms of blood work, the ones we think about are, like you said, I alluded to them earlier, the cholesterol, the A1C to measure diabetes. I would also check kidney function. I would check electrolytes, because some of the medications like hydrochlorothiazide and the rest of them that we need use for blood pressure control can cause dehydration, which can cause kidney issues. And they can also cause electrolyte abnormalities. Plus, when people have diabetes or they have high blood pressure they've had for a while, those can affect the kidneys, and people can end up on dialysis if the doctor is not monitoring them from time to time. So those are also particularly important. I also would recommend checking the thyroid, at least from time to time. The recommendation for thyroid is usually if they have symptoms that are concerning for thyroid abnormalities, or for cholesterol and thyroid and A1C, at least every 2 to 3 years. So those ones also should be monitored. I check for thyroid only because it increases the risk of arrhythmias, heart failure, and a whole bunch of other heart issues that we typically think about as well. And depending on the symptoms that the patient has, they can check your blood count, right? To check your hemoglobin, make sure it's not running too low, that sort of thing. So the typical sort of labs that we think about. And as somebody alluded to earlier too, I would also check the liver function from time to time, not on a regular basis, but especially if they're on a statin, maybe once a year, once every couple of years, I would check the liver function and just make sure that there are no major concerns there. Plus, if people are drinking alcohol or they're obese, people can also develop a fatty liver, which can cause liver abnormalities. So that's also another aspect of all of these that we have to think about, right? I think the whole body is kind of related one way or the other. There's no partition, but different parts of the body are related in different ways. And so we order certain tests that can affect the heart, but also can affect other organs as well.
Of course, of course. Well, you heard Dr. Okuosa. You need to remain active. You need to eat well. You have Rush Generations also offering not only physical classes, we have done other lectures, including the Mediterranean diet. So if you want to learn a little bit more, you can always go back and review those. Thank you so much, Dr. Okuosa. I don't want to take more of your time,
Thank you
but
so
we
much,
greatly
Priscilla.
appreciate that you joined us.
Thank you. It's been a pleasure. Take care, everyone. Remain
Thank you.
healthy, walk, exercise, do it all. Take care.
Exactly. Yes. Thank you. Take care, especially because the weather is going to turn very beautiful very soon. Well, that's what we hope. And one of the things that we also wanted to make sure that that all of you knew about, Rush is offering also heart and vascular screenings, and you do not need to have a physician referral. If you don't have also access to primary care to a physician, there's also that number 1-888-352-7874. And we will help you find a physician or a primary care physician. But if you're interested in having these screenings, heart and vascular screening, they are offered here for either $49 or $99, the package. I just wanted to let you know about this. We just wanted to let you know about this. You can call that number 312-942-5741. That is the Rush Imaging. And by pressing 2, then you can go in and speak with a scheduler. All right, so let's then tell you about the upcoming programs that we have coming up here in Rush Generations. The first one that we have is one of our classes, Embracing Aging. This class was designed to improve muscle strength, range of movement, balance, and activities of daily living so that you can remain independent. A chair can be used for seated exercises if standing up is a little bit difficult for you. So modifications are provided as well. The next class is going to be held via Zoom. We continue to do virtual classes on Mondays, starting on the 19th. That's next week through March 25th from 1 to 2 p.m. So give us a call if you're interested in that. Then we also walk with this. This is a walking group, a guided walking group that meets each week for 30 minutes to an hour to check in and to learn information on how to incorporate healthy habits before embarking on a self-paced walk for 10 to 45 minutes. So we guide you, and then we want you to continue walking on your own. The next session will be held on Wednesdays, Thursdays, and Fridays, 3 days in a row at the Garfield Park Conservatory here, very close to our medical center here in Chicago, the west side of Chicago. It starts also next week on February 21st through March 27th from 1 to 2:30 p.m. People love this walking group. So we are hoping that if you're in the area, you can join us. Then we have one of those evidence programs that we offer, and this one is for individuals with chronic pain. A 6-week workshop for people living with chronic pain. The Learning to Live Well with Chronic Pain. People that participate in this engage in discussion, skill building activities to better cope with the day-to-day management of chronic pain. And all the sessions incorporate an exercise element and strategies for medication management, for pacing activity and rest, etc. The next workshop is going to be held via Zoom on Thursday, starting in about 3 weeks, March 7th through April 11th from 12:30 to 3 p.m. So give us a call, 1-800-757-0202. That's our helpline and our registration number if you're interested in this evidence-based workshop. Then we continue to have this program, the Senior Connections Friendly Color program, which connects socially isolated or lonely older adults with a trained volunteer to receive these friendly weekly calls. The calls are designed to be participant-centered discussion, meaning that volunteers are calling just to establish a friendship and to make a genuine connection. So there's no structured screening questions, there's no interventions, no social work assessments. We truly want to connect with you so that you feel less lonely or isolated. So please call 1-800-757-0202 to get connected. We continue to want to hear from you, Shulman Senior Voices, which aims to empower older adults to discuss what matters most to them as they age. It is important to share what matters most to you with your physician and to loved ones. And this is one of the neat ways that you can do that because you always receive a copy of the recording. So Shulman Senior Voices wants to hear from you. So please consider sharing your wisdom on why it is important for your healthcare team and for your loved ones to know your goals and your wishes and what matters most to you. So you can either go to aging.rush.edu or scan the QR code that you're seeing in the screen to record on a mobile device or a smartphone. Thank you for joining us today. We hope that you will join us next time. Our next lecture is Coping with Long COVID. Is going to be next week, Wednesday, February 21 at 1 p.m. So we hope that you will join us.